So with that being said, I will now pass us to Dr. Sukhthankar, who will be introducing our esteemed presenter for today.
Thanks. So I don't know most of you. I'm Geeta Sukhthankar. I'm a professor of computer science at University of Central Florida, and I work with the InStep Methods core. And one of the things that we're really excited about is the application of natural language processing to mental health data. And while I was browsing on the web, I was really inspired by some of the tutorials that Dr. Antoniak had put together, so I invited her to do this presentation. So Maria Antoniak is a young investigator at the Allen Institute for AI. She earned her PhD in information sciences from Cornell University and a master's degree in computational linguistics from the University of Washington. She's worked at a lot of cool places: Microsoft, Twitter, Facebook, ETH Zurich. And also she's been awarded, so in our field of computer science, there are a number of Rising Star Awards for our junior researchers who are doing really cool, neat new stuff. And she's been recognized with Rising Star Awards in computer science and data science. So thank you so much for joining us, Maria.
Thank you for having me. Excuse me one moment while I now set up my screen again. Okay, almost. Okay, great. I think we're set up. So yeah, thank you so much for having me. I'm excited to talk to you all today. This will be a bit more of a, research talk about some of the things I've been working on and thinking about in relationship to NLP and maternal health and reproductive health. But I've tried to sprinkle in some kind of like introduction to NLP in here because as I understand, some of you maybe are newer to natural language processing and the methods in that field. So I've tried to add in some explainers where needed, but please feel free to chime in and ask me questions. I can slow down and explain a method. I'm also happy to talk afterward by email if there's anything in particular that, strikes your interest or a method that you want to know more about. I'll start with just a little bit about me and my research. So my research is to use natural language processing and also large language models, which is one type of method within natural language processing, to use these tools creatively to study human experiences. And I focus my research questions in 3 areas. So I'm interested in people. So those might be members of online communities, they might be healthcare workers, but how people are using language to interact with one another. I'm interested in subjective cultural concepts, things like narratives and values, and trying to use our computational tools to measure these subjective things. And then I'm really interested in person-focused healthcare, especially maternal health, pain, and reproductive health. Cultural analytics is one of the subfields where my work lies. This subfield is concerned with the computational study of cultural objects, processes, and agents. Traditional unsupervised natural language processing methods, like before things like ChatGPT or large language models, continue to be very popular in cultural analytics research, and you'll see that in some of the specific research studies that I highlight in this talk. It won't all be large language models, but of course, now that we do have these new tools, those new tools are also unlocking new ways to study human culture. And the first part of the talk will be about that. And more specifically, going into thinking about storytelling, this is a topic that I'm really excited about and very interested in computational approaches to storytelling and narrative analysis. And there are many reasons why I'm interested in this topic and the ways in which it connects with my other research topics, including healthcare. So as a rhetorical strategy, storytelling can drive social movements. It can spread misinformation, including health misinformation, but it can also spread good information. It can educate people. People like to learn through stories. Stories are compelling. As a form of self-disclosure, personal storytelling can strengthen social bonds, it can build trust within a community, and it can also benefit the storyteller's psychological well-being to share their story. As a sense-making strategy, communal storytelling can help individuals and groups learn from perhaps their shared healthcare experiences. And for NLP researchers, modeling narratives is a very challenging task, and we like challenging tasks in natural language processing because not all tasks are challenging. Some tasks are very easy for computers to do, and especially now with these new tools like large language models, some tasks that previously were very difficult are now very easy. But narrative analysis is not one of those. Storytelling is very complex. It's hard for humans to analyze narratives in a consistent way. And that's great. That gives us like a good challenge to work on computationally to see if we can get better at it. And storytelling also comes up a lot in the pre-training and prompting data that we use with these big models. So that's another reason why I and other NLP researchers are interested in storytelling specifically. And then going from storytelling into healthcare, the part of my work that focuses on healthcare is a little bit different from a lot of other work in natural language processing that studies healthcare. So within natural language processing, there's a subfield of biomedical NLP, and a lot of that field is focused on tasks like information extraction or diagnosis prediction, a lot of work on EHR data, more structured tasks. What I'm really interested in instead is text analysis to support people. So to support online health support communities, thinking about chatbots, things like ChatGPT again, and how they might or might not be able to support people through their healthcare experiences, and the types of sense-making strategies that people engage in during and after a healthcare experience. I'm also very interested in this field of narrative medicine, which lies at this intersection of the humanities, clinical practice, and healthcare justice, and intersects nicely with my computational work on narratives that uses patients' narratives to promote healing. So these are kind of the major threads in my work: storytelling, person-focused healthcare, trying to measure things that are difficult to measure, usually in a like community setting where people are interacting and talking or writing to each other, and using natural language processing tools to do all of that. Now, I'll give you a very brief, very high level, just a few slides, intro to natural language processing to give you some intuition if this is newer for you, of what do we even do in natural language processing? What does that mean? How do we approach problems? And what kinds of things are we trying to do in this field? Natural language processing, or sometimes known as computational linguistics, uses computational methods to study human language. This can include analyzing human language and generating human language. And our methods can include statistics, machine learning, linguistics, and programming, among others. And some examples of things that are powered by natural language processing that you likely use in your everyday life are things like Google search, chat and voice assistants like Alexa or ChatGPT, email spam filters, autocomplete when you're texting or writing. All of these are different applications of natural language processing. And within natural language processing, there's this what's known as the distributional hypothesis, this very famous saying that you shall know a word by the company it keeps. And this is what underlies almost everything in natural language processing, which is we want to learn about human language. We want to study how people write and speak. And we want to learn from those patterns, perhaps to generate language. And the way that we're going to do that, because we want to use computers, and computers don't know human language, but they do know numbers, is that we're going to study how words co-occur with other words. We're going to count up how many times each word co-occurs with every other word, and we're going to use those count patterns to do all kinds of much more complicated things. So in other words, we want to know which words often appear together. And what we hope and what we often find is that we can learn about the meaning of a word by studying its usage. And we'll often use a word's usage patterns as a proxy for its semantic relationships to other words. And just by doing this, by like counting up these co-occurrence patterns, we're able to do really amazing things like underneath ChatGPT, the first part of that, something that would power a model like that, is just this, counting up all these words and co-occurrences of words across a really, really big data set. And the other concept that's important to understand in natural language processing is language modeling. A language model is a model that assigns a probability to a sequence of words, or to all sequences of words. So given a word sequence, if I show you a word sequence, can you predict the next word sequence? And now we talk about large language models. So language models have been around for a long time, but more recently we talk about large language models, or LLMs. They're also referred to sometimes as pre-trained models or foundation models. And these models rely on vast collections of pre-training data. That's why we call them large language models. And common sources for that pre-training data include web scrapes, books, Wikipedia, Reddit, scientific publications, and anything else that those engineers can get their hand on, any human text that they can get their hands on. Code, I left that out. Code is an important other data source that's used for these large language models. It all gets thrown in, things get counted up, and out comes something like ChatGPT. There's some important risks to keep in mind, and we'll go a little bit deeper on this in a bit. But lack of interpretability is a problem with these big models. It's hard to say, you put something in, you get something out, and what happened in between is pretty hard to trace and to understand. And there's a lot of research in natural language processing on interpretability and trying to figure out how the model made the decision that it made. Giant data sets, these models rely on giant data sets that are very difficult to document. You may be familiar about this also, in the news. There's a lot of concern about that training data and where it comes from, copyright issues, who owns that data, is it okay for the people who created those models to take and use that data to train a model? And because the data sets are so big, even answering questions like, is my is my data in that model, or how many duplicate documents are in that data set? Those are very difficult. Like, we have to write research papers and come up with research methods just to answer those questions. So that's hard. There's poor representation and quality for non-English languages. Depends on the language, but in general, we have the most data and best performance for English. So if you're working with data outside of English, you might have a hard time using some of these NLP tools. And then there are all kinds of toxicity and bias challenges that are baked into these models and that are important to be aware of if you're going to be using these tools. And these are all things that NLP researchers are very interested in and trying to address. And there's a lot of research in each of these areas right now. Now, how do we use NLP models? So we have a bunch of pre-training data. That's all those documents that I'm showing on the left. They go into this model. Stuff happens in there. We have a model. And then we have really like 3 ways that we tend to use that model. We call it fine-tuning, few shot, and zero shot. So zero shot might be what you are familiar with if you've used a tool like ChatGPT just via a web interface or some user interface. So you just type in a query and there is some output. So you're not showing any examples, you're not teaching the model any particular pattern or to address any particular problem. You just give it one question and you get one answer back. There's also a paradigm called few shot. This means we give it a few examples. So you can do this. You can try this in your prompts. Again, within a web interface, you can do this. It just means that when you give that prompt, you also give a few examples of the type of thing that you're looking for. This is a really popular paradigm right now. It's called few shot. There's also fine tuning. So sometimes we'll take this big model and we will adjust it for a particular use case. Like maybe you have something very specific in mind that you want this model to do, some prediction you want it to make. And you have a bunch of data and you can show it many examples, not just a few. And you can actually adjust the inside of the model to better address that specific task. And that is called fine tuning. Within the world of LLMs for healthcare, there are many different tasks that people have been trying to use LLMs for within the healthcare context. So these can be things like information retrieval. So like find all the EHRs with patients aged 30 to 35. It could be a task like prediction. So given this health history, how likely is this condition? Could be question answering. So these could be like general purpose tools for patients or providers. We could be looking for linguistic patterns. So for example, like how do providers refer to different demographic groups in the records that they're producing? We could use these large language models for this type of analysis, for prediction, for question answering, for information retrieval. We could use the same model for all of these tasks if we use one of the really big models that is generalizes really well, or we could use a smaller model customized or fine-tuned to the individual task. So that's all I'm going to say as like background for natural language processing, very high level. If you're curious, on my website, there's a link to a set of tutorials and code and guides and recorded lectures called AI for Humanists. We gear it towards researchers in the humanities, but I think it would be applicable to researchers in other fields as well, and gives you some nice I think, intro and more in-depth intro than what I was just able to provide. If you want to go deeper and try some of this out yourself, that could be a good resource. But now let's back away from the intro to NLP and talk about some research topics that I've been really interested in. So I have 3 things I want to talk to you about today. We'll see if we get to all of them. But the first one is considering this question of natural language processing tools for a particular healthcare topic and how we should or shouldn't be using natural language processing when we approach a healthcare topic in particular. There's a lot of hype right now around natural language processing and large language models for healthcare, and we wanted to focus on a very specific healthcare topic and really think through some of the risks and benefits to using these kinds of tools in this kind of high-risk setting. This was a collaboration between the Allen Institute for AI, which is where I work, the University of Washington, UC Berkeley, UCSF, and the Center for Health Justice at the Association of American Medical Colleges. We gathered perspectives on large language models and natural language processing tools from a bunch of different groups, and we developed guidelines for using natural language processing for maternal health specifically. There are existing guidelines. So, if you want to find some guidance on how to use machine learning or natural language processing tools and methods in general, in an ethical way, and for healthcare more specifically, there are existing guidelines. Most of those guidelines focus on a traditional development pipeline and give recommendations related to each pipeline step. And the guidelines in these prior works are based on literature reviews and broad sets of healthcare examples. They're not usually focused on one specific healthcare setting. And they're drawing their guidance from looking at the field, looking at the prior work, and summarizing those best practices. What we wanted to do was to narrow our focus. So we build on this prior work that constructs these ethical guidelines for machine learning practitioners by narrowing our focus in 3 ways. So we wanted to consider NLP methods and applications, especially large language models, not all of machine learning, but specifically natural language processing and large language models. We wanted to directly solicit perspectives from many different affected groups. So rather than us, reading the prior work and sitting and coming up with what we thought would be the best practices, we also wanted to directly engage with the people who'd be most affected. And we wanted to focus on a specific healthcare topic, in this case, maternal health. Why maternal health? Why not a different healthcare topic? 3 reasons. So one is that there are already a lot of prior research studies and applications of natural language processing methods focused on maternal healthcare specifically. So we have a lot of examples to work with, and we know that there is definitely interest in applying NLP methods to maternal healthcare challenges. Second, pregnancy and childbirth are very common events that often comprise a person's sole or major interaction with the healthcare system, which increases the significance and also abundance of perspectives on this particular topic. So out of all possible healthcare topics, maybe this would be a good one to focus on because of its relevance to many people. And third, perhaps most importantly, maternal health is a perfect storm of healthcare vulnerabilities with historical biases, abuses of power, shifts in power dynamics that influence care, entirely separate from anything related to AI, machine learning, or natural language processing. There's a long history, a long complicated history. Thinking about how natural language processing and large language models would interact with that history, with those power dynamics, was something we were very interested in. And so for these three reasons, we wanted to focus on maternal health. We talked to a bunch of different stakeholders, including birthing people, nurses, pharmacists, community health workers, physicians, healthcare management, population and public health researchers, and local and state public health workers. We wanted to talk to a bunch of different groups as we develop these guidelines. And the overall form that our study took was in the first part, we solicited these perspectives. Again, we wanted to speak to people directly, so we did that in two ways. We hosted a workshop with the Association of American Medical Colleges. It was hosted by them, and then within that workshop, we had a particular session that we were in charge of. There, we had 236 participants in our session. And then we also solicited perspectives via an online survey platform, Prolific, to get additional perspectives from specifically birthing people and medical professionals. In both cases, the experimental procedure was very similar. We let these cohorts of participants interact with a large language model with GPT 3.5. We created a wrapper around an interactive demo around GPT 3.5, let people interact with that chat interface, and then surveyed them and led moderated discussion groups with the participants to hear about their experiences, both with that particular chatbot and then more broadly about NLP and related technologies and their relationship to maternal health. We then analyzed all that data, incorporated insights from prior work, aggregated common themes, and then derived our set of guiding principles, which we divided finally into a set of 9 principles, 3 themes, and those 3 themes were context, measurements, and values. I'll go into those in detail in a little bit. The workshop involved research talks, trainings, breakout sessions on many different topics related to maternal health and natural language processing, including the kinds of social biases that are baked into these models. This is a beautiful illustration that came out of that workshop. And the workshop participants opted into the workshop, unlike the survey participants who were, solicited and paid for their time. The workshop participants, they opted in on their own, and they went through most of the workshop before reaching our session. So unlike the survey participants, you could consider them as a trained cohort by the time that they reached our session. This is what the chat interface looked like. It was, instead of side by side, it would have been scrolling down. But we wanted to provide this guided interface to this large language model. And what we wanted was for people to engage with this chat interface by asking questions related specifically to maternal health. But then it could be anything related to maternal health, could be related to their personal experience, their expertise. It could be hypothetical. But before the question that they ask here, we also ask them to explain the background to their question. So they can ask as many questions as they want. We were given about 20 minutes to interact. And then after each question, we asked them, what did you think about the response from the model? Was it accurate? Was it trustworthy? Was it useful? Was it up to date? Or are you not sure what to think? And then after that interactive session, we then had these breakout moderated discussion rooms where we went through a set of 4 high-level questions. How was your experience with the chatbot? What stood out to you about the responses from the model? What are your dream NLP tools for maternal health? What tools should never be built? Which maternal health stakeholders, birthing people, nurses, doulas, etc., would benefit or be hurt by natural language processing tools? And what principles should guide the use of NLP for maternal health? What should be the goals and guardrails? So these were moderated sessions with the workshop participants. With the online survey participants, we'd ask them to write out their answers to these questions. Our final set of participants, so there's 3 cohorts. The workshop cohort is what I'm showing at the top. That was the largest. We had 39 people who ultimately filled out all the paperwork and the survey and participated in the discussion. And then we had 30 healthcare workers and 30 birthing people who participated via the survey platform, Prolific. The workshop participants on average were reported being less familiar with AI, machine learning, or natural language processing than the participants we recruited from Prolific. We asked them, how familiar were you before the workshop? And the workshop participants had overall a slightly more negative view on average of AI than the Prolific workers. They had just exited a previous session run by Ruha Benjamin, who is a fabulous researcher at Princeton who studies, among many things that she studies some of the racial biases that are baked into these AI models. So they had just come out of a session with her. So I'm not totally surprised to see this more negative perception coming up in the survey results from the workshop participants. And overall, we didn't see big differences in their reported general trust or their trust in healthcare providers specifically. So all this is to say that we had these 3 different cohorts. They are not exactly the same. They were not primed in exactly the same way. We're not trying to prove anything about the differences between these cohorts, but we did want to talk to people in different settings and from different backgrounds, but who each had some kind of investment in maternal health. And what we asked them as part of the survey was to rank a set of 12 values. These values come from a prior study. We asked them to select the most important values from that set that were the most important when applying natural language processing methods to maternal health. So these values are things like safety, privacy, human autonomy, performance, transparency, fairness, etc. And we found that these different groups of participants did indeed have different views of the values that should be prioritized. For example, birthing people prioritized social good over the other groups, and the healthcare workers prioritized accountability over the other groups. So there wasn't one uniform view of what should be prioritized. And from our participants' discussion, the survey results, including what I just showed you, and prior work, we derived our set of 9 guiding principles for the use of NLP for maternal health care. Each principle includes discussion, representative quotations from our participants, and practical advice for researchers and practitioners. And this work led not just to the kind of academic work that I'm showing you right now, but also to what a set of foundations of responsible NLP use for maternal health equity, which is a tool hosted by the AAMC and used to improve AI literacy for maternal health care workers. And you can read more about that on their website. But to dive into our set of 9 guidelines, so I'll go 3 by 3 through our different themes. The first theme was recognizing contextual significance. And within these 3, the first principle was to be aware of power dynamics in the care team. And here we were really inspired by a prior work, a book called Data Feminism by Catherine D'Ignazio and Lauren Klein. They argued in that book that power should be a central concern of feminist data science, and maternal health care has a long and fraught history of shifting power dynamics in the care team. And these historical shifts, for example, male OBGYNs replacing midwives in the early 20th century, have led to the marginalization of some maternal health care workers, and both good and bad consequences for birthing people. And what we'd like NLP practitioners to know is to know this history and work to improve rather than exacerbate existing hierarchies, being mindful of the impact of tools and automation on midwives, doulas, and other care workers whose placement is already precarious. So for example, one of the healthcare workers in our study mentioned that an AI chatbot could eliminate the need for a doula, highlighting the vulnerabilities of certain workers in the eyes of other healthcare workers. One of the birthing people framed this as a harm rather than an opportunity. They said, if mothers relied too heavily on AI instead of seeking professional help, then the nurses and doulas may see fewer people seeking care. The second principle in this section is know the politics and implications of your measurements. So here we wanted to highlight that NLP tools, when used for data collection, can have unintended consequences that can impact the safety and agency of birthing people. So for example, overemphasis on data collection can draw resources away from building solutions. Reproductive health is politicized, and measurements may be used as evidence in support of unexpected agendas. If you don't think through ahead of time, how am I presenting my results? Why are we measuring what we want to measure? You could be surprised by how the results of your study are framed and used by others. That's something that is worth thinking about ahead of time. And focusing only on measuring problems can contribute to what are known as deficit narratives that blame communities for their own challenges. In our literature review, we found that a lot of prior NLP research for maternal health has focused on data collection and surveillance of birthing people. So there are like so many studies monitoring the mental well-being of birthing people, probably all very well intentioned, but when you look at it in aggregate, it's a lot of surveillance of birthing people and not a lot of attention paid to the clinicians and other healthcare workers who are involved in maternal health. And one of our participants pushed back against this pattern. They said it's key that the AI is actually able to provide solutions to problems that can be fixed and not simply acknowledging them. So not simply measuring problems, but also trying to provide solutions. Financial motivations also muddy those decisions, with the healthcare industry often focused on reducing costs. And one of our participants said, I get worried about what'll happen when insurance companies think there's cost savings to using these tools. They can cut corners, have more profit, given the incentives in the healthcare system. And then the last principle in this section was to learn from maternal health traditions and communities. With thousands of years of cultural traditions, healthcare practices, and tool development related to maternal health already, and NLP practitioners should learn from those traditions rather than reinventing the wheel. One of our participants said, people have the mindset that this needs to actually replace things, or that this needs to be the way in the future of addressing maternal health, diminishing all the work that's been done in the past and the positives of having people that truly understand this work. Learning from traditions and communities could help avoid repeating mistakes made by others. So another participant said, it should follow, it meaning AI, should follow the same guidelines that medical professionals do no harm. Our second set of principles were grouped under a theme of holistic measurements. And the first of these principles was to optimize for outcomes that support the whole person. And I really liked this quote from this participant. They said, it's not just about the outcome, right? It's about the whole experience. And for maternal health in particular, I think that's so true. Most NLP research is focused on these structured tasks with defined and accessible outcomes, like trying to predict whether someone will have postpartum depression. And those kind of tests are important, but so are other outcomes like achieving a positive birthing experience or breastfeeding without stress. As one participant said, it would be great if AI could tell everything from conception to birth. That would be great. We're not there yet, but yeah, indeed, that would be great. And taking a more expansive view of the tasks and optimizations that could benefit maternal health stakeholders could open the door to other opportunities. And the second principle here was to protect all groups of birthing people. The healthcare system treats people differently. We know that it does on the basis of race, class, gender, and other attributes. Natural language processing models can mirror those biases that are found in their training data sets. And everything that has the potential to benefit also has the potential to hurt, in the words of one of our participants. So in evaluating NLP systems, one should consider both the disparities in impact and disparities in treatment. Tools should, quote from a participant, allow providers to improve their own cultural competency or race consciousness and empower those lacking social and financial support, such as young birthing people. And lastly, hold on to the human, empathy, emotion, relationships, and complexity. So this, of course, is a topic close to my research interests. Emotion, empathy, and storytelling, these are all important components of healthcare, and natural language processing tools should account for such human elements, remembering that each birth is unique and each birthing person has a unique set of circumstances, experiences, and preferences. One of our participants said, human connection is important and should be emphasized so that better quality service can be provided. Another person said, your own judgment and human compassion, wisdom, and experience are a part of the care. And we think that workers with language data, as opposed to structured data sets, open doorways to subjective tasks like measuring empowerment, agency, or sentiment. And another final quote for this section, birth is so complicated, though, that I don't see women ever replacing a medical care with AI advice completely. And then our last set of principles, grouped under the theme of who and what is valued. The first principle here was to include the voices of those who are seeking care. The voices of the most vulnerable group, the birthing people, the most directly affected, should be included in the design and the development of NLP tools. Centering the principle of nothing about us without us, most recently popularized by disability activists, is really important. And while it may not always be possible to include birthing people on a research or production team, it's important to integrate their perspective throughout design and deployment processes through surveys, user studies, or other methods. As one participant put it, there needs to be community input, there needs to be representation in creating these tools. Second, always center the agency and autonomy of the birthing person. Maternal healthcare has this unfortunate history of abuse and disregard for the birthing person's agency. And natural language processing practitioners, even when studying topics like misinformation, should not work from a perspective of skepticism about the birthing person's ability to make decisions for themselves. How NLP tools are being used to make decisions in maternal health should be disclosed to the birthing person, such that, to quote a participant, the person using it knows what kinds of information or advice it can give and that it cannot give. Correspondingly, there are some tools that perhaps just shouldn't be built, such as, in the words of one of our participants, anything infringing on the rights of the mom or the baby. And then the last principle, respect and support for data sources. So generations of birthing people have passed down oral stories, they've written books, created online content about pregnancy, labor, and postpartum. And NLP studies and tools often benefit directly from that knowledge and data and should give credit, at the very least, and be designed to avoid supplanting systems of support that are already thriving. As several of our workshop participants observed, ChatGPT and similar chatbots don't really note their references of where they're getting information from. And the principle that should guide these tools is to have transparency for its sourcing of data. Now, overall, in our discussion with our participants and the survey results, our participants reported largely positive attitudes towards the NLP tools with some important caveats. So, for example, our workshop participants expressed high hopes about the development and adoption of NLP tools in healthcare, but all of them agreed that NLP tools for maternal health should always be designed to be assistive rather than autonomous. And settings in which NLP tools were viewed to be particularly useful to healthcare providers included reducing administrative burden and improving medical education and training. On the other hand, tools for decision-making settings were viewed negatively. These results contrast with current trends in natural language processing research that I mentioned, which tend towards surveillance of birthing people and tasks like risk prediction. Those are the opposite of what our participants were calling for. Birthing people viewed NLP tools very positively, especially for providing information and recommendations. For example, participants wrote that they wish they had the chatbot during their pregnancy. One person said, I wish that it had been around when my son was a newborn so I could interact with it during late night feedings. 1, to give me something to do, and 2, to make me feel like I wasn't alone. And they emphasize how comforting it would be to have this fast and convenient resource to address fears they have, whether what they were experiencing was normal. One participant said, just to have something there to ask questions to when I'm not sure as to what is happening or when I need a quick answer. In their free text responses, about half of the birthing people and 2 of the healthcare workers compared their experience with the chatbot to their past experience with internet search engines like Google. Most frame that comparison favorably, writing that oftentimes people will Google questions and try to sift through all the search results, try to find applicable information. AI could make that a much more efficient process. And another person said it would be nice to be able to type in worries and fears to an AI bot and get accurate answers instead of going down rabbit holes on search engines that leave you more concerned. And this was something we didn't prompt for. They drew this comparison to search engines themselves. On the other hand, one participant noted the dangers that are similar to known dangers of popular healthcare websites. They said people already diagnose themselves on WebMD, providing more tools could be dangerous. And these participants viewed large language models as one more tool in an existing information ecosystem, exacerbating or ameliorating many of the same challenges. This view is complicated by recent work, for example, by Shaw and Bender, that emphasizes the risks of using these chatbot tools as replacements for traditional search interfaces, both to their users because of hallucinations and the errors these models can make, and to entire information ecosystems that can be polluted by incorrect and ungrounded outputs of large language models. It's already happening. When you Google things, you'll often, what you will find are outputs of these language models that may or may not be correct. And that work by Shaw and Bender calls for slower research that prioritizes answering fundamental questions about evaluation, costs, et cetera, before deploying these tools as information retrieval systems. So there's a tension here between what is emerging as important risks in the field and perceptions of the users of these systems. And there's a lot more data that we collected as part of this study that we haven't fully uh, uh, had time to analyze yet. There's a lot more that we want to do with this data. So we also collected the query data that people were inserting into the chatbot. And I'm showing here some initial analysis of that data where we grouped the queries according to qualitative themes. It's a small but high quality query data set written by a bunch of different people related to maternal health and on this specific healthcare topic. So it's a bit of a unique data set compared to other NLP healthcare data sets. And I'll show you a couple examples. So of the themes that we've pulled out, there are a lot of questions around best practices. So people asking the model, what should I do? What is the known best practice for this scenario? There are a lot of people asking questions around symptom interpretation and risks. Also asking the model to assist them in weighing options and finding resources. And here's an example. So again, we asked them to both provide context for the query that they were writing. That's what's shown on the left. And then the query itself is shown on the right. So these were all queries grouped under the theme of seeking definitions and information. So these were questions like, what is a labor induction? What is the difference between preterm labor and Braxton Hicks contractions? How often is Pitocin used? And then one of the themes that I find really interesting and didn't expect ahead of time was there were quite a few queries related to planning communication with a provider. So trying to script out a healthcare interaction ahead of time. And in the context that the users provided, the participants provided, they often would give context indicating that their motivation for this query was based on previous healthcare interactions where they felt dismissed or they felt that the provider wasn't taking their concerns seriously. So for example, in this first row, it says she's at her appointment with a new provider and considering sharing what she's been feeling, but she's hesitant because she's been ignored by providers in the past. And the question is pelvic pain normal for first-time mothers? So it's people trying to, again, plan out interactions with healthcare providers by play acting or getting new patterns for how they can phrase their questions by using these chatbot tools. Okay, so that was my first time talking through that paper, and it took a lot longer than I thought it would. But that is my most recent work in this space of NLP and maternal health, and the one I'm most excited about. I'll just I'm going to skip over this particular study. We had some prior work using NLP tools to analyze the narrative shapes in people's birth stories, and examining the like diverging pathways and framing that people brought to their birth stories. I'm going to skip over this, sadly, but you can find the paper on my website if you are curious. And then I'll just briefly touch on this study about sense-making, about contraceptive methods across online platforms. So just gonna like very briefly give you like a little bit of an applied view, not using large language models, but using some different methods from natural language processing to analyze the types of healthcare support that people are seeking and providing in online communities. So birth control plays an important role beyond contraception. It can be used to treat and manage many different medical conditions. But because birth control methods are not one size fits all, and the choices of whether to use birth control and which method to select are complicated by many different things, including personal belief, cost and accessibility, and a wide array of side effects that are difficult to predict and identify. When navigating this decision, birth control users face a sense-making challenge, and many people in this situation turn to online communities and online discussions to help them work through their decision-making process and understand their healthcare experiences. And we had a couple different research questions going into this study. We were interested in which birth control methods and side effects are more likely to be discussed on different online platforms. And we were also interested in what kinds of sense-making activities birth control discussants engage in online and how those differ across platforms. So I'm just going to give you like a kind of teaser view of this study. Again, if you want more detail, you can find the paper on my website. But we collected a bunch of data from Reddit and from Twitter, both Reddit posts and comments and Twitter posts and replies. And we used 3 different methods. Again, relatively simple methods compared to the big models that are very popular now. We used customized lexicons, so lists of words and rules, to identify both the mention of different birth control methods, like pill or IUD or implant, and different side effects. And then we use a method called topic modeling and a specific topic model called method called latent Dirichlet allocation to extract themes from the discussions that we were examining. This is an unsupervised model, which means that we show it a bunch of text and it will then tell us these are the primary themes in this collection of texts. And again, just as like maybe a teaser for you to go and look at the paper in more detail, one of the first things we found, just looking at the frequency of the mentioned birth control methods, were large differences, both between birth control methods. So we focused on the pill, IUD, and implant as the most common reversible methods discussed on these platforms. So we see big differences between the different methods, between the different platforms, and over time. So in general, we find that on Reddit, the pill is discussed more often, whereas on Twitter, there's been a change over the years, but now the IUD is discussed much more than other methods. And we also found differences across the platforms and across the methods, but more interestingly, I think across the platforms in what types of side effects are discussed on these different platforms. So for example, side effects like bleeding are more discussed on Reddit, while side effects like stroke or heart attack are more discussed on Twitter, these more like severe side effects. And last kind of teaser result from this study, this is from the topic model. So here we were extracting these sense-making themes from the discussions happening on these different platforms. And our final set of sense-making themes included storytelling, risk analysis, timing and calculations, method and dose comparison, and causal reasoning and information explanation. So I'm showing 4 of those here: storytelling, information explanations, risk analysis, and timing and calculations. And the associated topics on Reddit and Twitter and how strongly associated those themes were with the different birth control methods. Those are the columns: IUD, implant, and pill. And we find that there's a greater number of storytelling topics for the IUD and the implant than for the pill. And examination of those topics shows that insertion and removal experiences fuel that pattern. Each of the methods is associated with risks and is included in method comparisons, but the pill in particular is included in discussions of timing and calculations. I'll skip this and just say a little bit about future work and what I'm interested in doing and where I see interesting work happening around LLMs, NLP, and healthcare. So one is around modeling narratives. Again, storytelling is this really powerful driver of community sense-making processes that can also spread misinformation. We found that also in the contraceptive study, that storytelling was an important sense-making strategy in those communities. We need more studies, and more studies, I think, on the computational side that are also drawing on this field of narrative medicine. Within the realm of LLMs and healthcare, we need new solutions so within healthcare, we need new solutions to big challenges like lack of accessibility, physician burnout, and we need every tool in our toolkit, I think, to help us address those challenges. And we're already observing care seekers using large language models to script communication with their healthcare providers, to seek information and complete other tasks to support themselves. But there are many risks involved in using NLP to address those challenges, things like power consolidation, privacy implications, biases, and errors. So we need people who have deep knowledge on the healthcare side to be involved in these conversations and in this research, as we figure out where, if anywhere, large language models can really be helpful. And then I also think we need a lot more work on the probing of these large language models. We need more stability evaluations when using these models for small and socially specific data sets and tasks that also come up in a healthcare setting if you're interested in a particular healthcare topic. And we need more benchmarking of model performance across domains and communities, measuring variation in and across specific cultural contexts. And you could also think across different healthcare settings. So those are the places where I think we really need more work, where there is more work happening, and where we also need this conversation between healthcare researchers and natural language processing researchers. That is all. Thank you so much for listening. And we have maybe a couple minutes for questions.
So I'm going to jump in. Greg Ahrens, UCSD. Thank you. Great talk. Ton of really interesting and work that can improve the lives of people seeking healthcare. It's opportunistic. I just came off a meeting with Dr. Irene Su, who's a OBGYN cancer researcher, and I'm involved with the project on her on helping patients navigate fertility preservation benefits. And I just wanted to bring this up because the complexity of, so there may be political mandates, and so that's one piece of the puzzle, but health insurers design their health benefits in many, many different ways. And I think the implications for how health systems interpret the benefit packages and how those are or are not communicated to patients is really a sort of a difficult problem. In 2 minutes, can you solve this problem? I just wonder what your thoughts are with all that complexity and how we can help the patients better navigate this.
Well, I think that is a perfect example of some of the tensions I was highlighting in the talk between what users of these systems are doing and what they are themselves finding helpful and report finding helpful, and what we know from the research side and from the practitioner side is risky. So this is a simplification and summarization are two tasks that these big models, so things like ChatGPT, are in some sense really, really good at, that you can give it a text like this complicated insurance documentation and ask it to summarize or find the information that's most relevant or explain it in a way that I can understand, using words that I know. Those are things that on the surface level, these models are really good at, and that anecdotally I hear again and again and again from people in my personal life, at work, that this is how people are using those models, and that they report that it is working for them, or working well enough for them that it's worth using. But these models come with all the risks that I talked about in the talk. They can hallucinate, they can give you inaccurate information, they can leave out information that might be very important. So no, I don't have a solution in 2 minutes, but I would say it's a great example of risks and opportunities in the current state of the field.
Yeah, thank you. I see that Dr. Rabin has her hand up also.
Thank you. I know we are over time, so my question is very brief. First of all, this was fascinating, and I can't wait to dig into this more. If we wanted to incorporate AI and natural language processing into our own work, what would we do to learn about this more and to engage the right people to help us?
So if you immediately want to try something, again, you can go to our AI for Humanists tutorials. I promise I'm not just trying to plug them. They're designed for exactly this, to help you go deeper and to not hide the technical detail from you. And so we have what are called Google Colab notebooks. So you won't need to download anything. If you're new to coding, you won't have to download or set up anything, but you can immediately start working directly with exactly the code that I use myself when I'm fine-tuning a model. So that is all available on that AI for Humanists website. Otherwise, I mean, collaboration. I think people on the AI and NLP side, a lot of people are I think very eager for collaborators and don't know where to find the healthcare collaborators. So I think if you reach out to people, you might find a collaborator who's excited to bring those methods to your research problem.
Thank you.
I know we're over time, just a real quick question. And I think you sort of touched on this, but as far as the care-seeking behaviors and the risks and rewards of that, I know the guidelines that you put together are a little bit more higher level, maybe a little more oriented towards the healthcare workers and how they should understand and maybe communicate this with some of the individuals we're working with. But is there work that you're either aware of or things that even can help ChatGPT give you better results? And are there some guidelines and strategies and things to support the care seekers in that type of effort to try to improve and the quality of the responses and minimize the risks of hallucinations?
From the care seekers' perspective.
From the care seekers' perspective, yeah.
That's a good question. I mean, to some extent, no, there isn't much as a user that you can do to influence these big tools like ChatGPT, these
Right.
public facing tools. There's things I think you should know. And I guess I'll plug another thing. We have a article on Medium. I'm blanking on what the title is, but it's something like what you should know if you're using tools like ChatGPT, as a user. So things like, yeah, it can hallucinate. It can just make up an answer that has nothing to do with reality. It can be biased. It can give you bad, toxic, harmful advice. So we just list out the things that we thought were most important for the users to know.
That's
Yeah. I mean, then there's a whole question about advocacy and political action, and that's where definitely users can be more involved, but that also I think requires understanding more, reading more, understanding the same problems I was just talking about, and then advocating for better tools.
Thank you.
Also, I'm happy to stay as long as you want. I can stay here and keep answering questions.
That is so kind of you, Dr. Antoniak. I see we have maybe we can take this one last question. Looks to be from Mercy Oladipo. I hope I'm pronouncing your name correctly, but
Yeah, good job.
Thank you.
Hi, Dr. Antoniak. I had a question. So you mentioned on some of the slides previously around like physician burnout, and I know there's been a lot of work also looking into like alarm fatigue with nurses, things like that. When it comes to using NLP for like clinical decision making, have you found anything that's interesting or potentially like good takeaways with it, like in terms of how do physicians want the information presented? You know what I mean? 'Cause I think oftentimes like work that usually excludes clinical collaborators just like puts really a lot of info on there 'cause you think that they want all the insights possible, but then they get overwhelmed. So when it comes to actually giving feedback that can be actionable and useful, do you have any takeaways of what that could look like?
Yeah, that is a really great point. And I'm just picturing all like there's so many studies in natural language processing on like summarizing or generating like EHR, like writing the notes for the clinicians, but not a lot of that work actually engages with the clinicians and asks them like, what do you want the note to look like? Like what would be most helpful if we could generate whatever you wanted, like we're not constrained anymore by you writing this. And to be honest, I don't know of much work off the top of my head um, that considers that. There is some work on the types of like sense making biases that researchers and users of these systems bring to their interpretation of outputs of these generative models that would be related and could inform that design. But no, I don't know of a study that directly addresses that question.
Okay, thank you.
The only one that actually, we'll just go all the way back. There might be something useful in, almost there. In these two studies at the bottom. So there's a study on developing guidelines for the deployment of sepsis detection, and then this other study on developing ethical guidelines for NLP for early detection of Alzheimer's disease. And if I'm not mixing up something, I think at least one of those studies had some like direct input from the clinicians, and that might be a good place to start.
Okay, thank you. Appreciate it.
Well, again, thank you so much, Dr. Antoniak, for joining us today and guiding us with this really fascinating presentation. If I'm not misunderstanding, I believe you had agreed to potentially share your slides.
Yes.
Okay, perfect. Thank you. So certainly we can pass on these slides to anybody who is interested in them. Again, thank you so much. Such a fascinating presentation. And we appreciate you and everyone else staying on a bit late to continue with the engaging discussion.
Yeah, thank you so much for having me, and happy to answer more questions by email if anything comes up. Thank you.
Lovely. Thank you so much. Take care, everyone.